Now we're recording. Good evening. Thank you for the 11 out here that have joined us. We're going to have you mute your microphones. If you cannot hear me, go into the chat box and say something. If you have a question, Casey will answer it or I will answer it. If you go into the chat box, and also feel free to wave. We're sorry that this didn't work out on Facebook. That only cost us an extra $500 for that mistake. But that's okay. I am Dr. Sallie Sarrel. I am a pelvic physical therapist practicing in New York and New Jersey. And after really what was a 23-year battle with endometriosis, I founded the Endometriosis Summit with Dr. Andrea Vidali. And he and I really believed that we would be in a little tiny free conference room in the hospital, how many people could show up. And within 2 days, we sold out last year and we emerged into the largest patient-based conference for endometriosis in the United States. We are adding not only a live surgery this year, but we are adding an Endometriosis Summit workshop day so that everybody can explore their own individual topics of endometriosis. And there's a large component of that includes being minimized and medical trauma. So I have invited for our first, I call it a Facebook Live, but I guess I should start calling it a Zoom Live. Our first live experience, I have invited the esteemed Casey Berna. Casey is a social worker who works in infertility and endometriosis. She has endometriosis herself. She has survived infertility as well. And she led the charge in the patient petition to ACOG, and she can talk about how the standards of care that exist currently feed into trauma a little bit, perhaps at the end.
Yes.
So Casey, why don't you tell us a little bit about yourself?
So as you mentioned, I am an endometriosis patient. Like so many other patients, it took me a long time to get diagnosed. And for many years, I was dismissed. I was misdiagnosed. And I was finally diagnosed by a reproductive endocrinologist. But again, like many other patients, the reproductive endocrinologist didn't understand endometriosis really, or the scope of how sick I was. So, you know, I've dealt with endometriosis, I've dealt with infertility, I've dealt with recurrent pregnancy loss. And after coming through all of that, I realized my field of social work was very appropriate, that going through endometriosis and infertility had a very big impact on my mental health. So I was assuming when I reached out to others in the community and started doing advocacy in the community, I realized that it impacted others. So I realized that, you know, I worked as a school counselor and worked in different areas of social work, but then I started working in this field and found that my experiences of being dismissed, my experiences of trauma was not unusual, and it was the experiences of many patients, in part due to the lack of standards that were necessary that patients needed and the lack of collaborative care.
What do you think it does to someone's emotional well-being to be minimized for so many years?
I think being minimized for so many years has a profound impact. I think when you go to a provider and you're listing so many symptoms, I know for me as a patient and my work with patients, it feels like your entire body is failing you, right? My bowels were a mess. You know, my bladder, basically it seemed like every system of my body was going against me. And yet I went from provider to provider, and all of them said, you know, nothing's wrong with you. You're fine. Maybe it's stress. Maybe it's your anxiety. And I have to tell you, I had anxiety because my body was failing me and no one could give me answers. So I think being minimized and dismissed. I know, even I can remember little things like going to a regular gynecological appointment, right? And having the speculum entered and me saying, whoa, that's painful, or like shrieking back, and the provider saying like, that shouldn't be painful, or that shouldn't hurt that much. Just little things like that just felt traumatic and felt so big. So I think it has a profound impact and heightens anxiety in patients. I think it could cause depression in patients, the minimization of pain and the dismissal of symptoms. And, over the course of time, it just is like a snowball. And unless you have collaborative care and the intervention you need, it really can have a serious impact. I really believe these things are traumatic events. And going through it, it's funny, I can remember going through different procedures and someone be like, well, how was it? I'd be like, it felt traumatic. And reading this book, this author, said it is a trauma, and patients can have PTSD from it.
Yeah. I always say that, especially in my life, but to my patients as well, we almost have no safe space. Like, think about that. 200 million women worldwide are missing a safe place because their bodies can't serve that for the role for them. So why don't you tell people you were talking about a book. Can you tell everybody a little bit about the book?
Yes, and I'm reading some of the comments, and it is frustrating not to be heard and not to believed. And so, so the book I read, I always felt like what was happening to me felt traumatic. And when talking with patients, I said, that was traumatic. And then reading this book, it's an excellent book. And it's by a woman who, it's called Managing the Psychological Impact of Medical Trauma. And the author's name is Michelle Flom Hall. And she wrote it with her husband, Scott E. Hall. And she wrote this book after she had a traumatic birth experience where she almost died. And what dawned on her is that a lot of times in medical settings, no one's really thinking about the psychological impact of what is going on with patients or talking about it. And so she sort of broke down medical trauma, researched medical trauma, and really broke it down in a way that rang true for me as an endometriosis patient, infertility patient, and mental health provider.
Okay, Casey, so can you break down trauma a little bit for us? And then after Casey breaks down trauma, we do have a question from Rachel, and we're going to get to the question afterwards, okay? So tell us a little bit, like, can you define trauma? And then can you then take that definition and define trauma as a person with endometriosis?
Absolutely. So, and I see the request to put the link to the book, and I'll absolutely post the link to the book. And there's also traumatic to you, then it's a trauma, which I think is wonderful, because I think oftentimes we're dismissed, or other people dismiss us. Oh, that wasn't traumatic. Or she's like, no. If it feels traumatic, then it is a trauma, which I think is important for endometriosis patients. And then she talks about how she breaks it down into 3 levels of trauma. I think she breaks it down. The level 1 trauma was talking about the trauma you can experience just at your regular provider. So we were talking about this a little bit before. Even sharing our medical histories can feel traumatic. I don't know if you've ever had that experience where just going in and sharing your medical history with a new provider can feel traumatic.
I definitely have. And I think also every time you go to a new provider, a lot of times you'll get the PA or the nurse, not that I don't love PAs and nurses, or you'll get the resident, and then they'll be like, well, why don't you just have a hysterectomy? And it's like, A, I'm usually not in your office because I want to talk about hysterectomy, and B, that doesn't even fix my problem. And then my response is anger. And what I learned from reading your blog is that's like really the trauma probably sitting in my, I mean, also we're fed up as endometriosis patients, but the trauma sitting in the cells is sort of boiling over.
Yes, absolutely.
Yeah. I think that's
Absolutely.
very interesting.
And it's hurtful, right? It's hurtful and it's re-traumatizing and it feels dismissive. So I think that anger is, and there's grief too, right? We all carry grief with us, and anger is also, grief can be expressed as anger as well. So,
and what are some of the other levels of trauma? You were saying the first is, you know, when maybe when you go to a doctor and you're minimized. What are the other two levels?
yeah, so the first is, you know, being minimized, how, you know, sharing history, even what would seem a simple exam like a pelvic exam is not so simple for us and feels traumatic for us. And the tricky part of that is that providers may not always be aware that
Mm.
with that, how it can impact, and she talks about how often with progressive and chronic illnesses, there are secondary stressors. So not only is it really difficult, right? We're constantly going to doctors or, you know, different therapies to try to manage our disease. So just the act of having to manage medical care is very stressful in of itself, and going to appointments, and not being able to always count on our bodies and know what to expect from our bodies. And then often with, you know, chronic illnesses come secondary stressors, like it impacts our education, our job, our relationships, and that causes more stress and trauma.
And how many of your patients, when you treat endometriosis patients, how many of them do you feel were their lives were changed on a daily basis? So I know the statistic says that on average, people with endometriosis lose 11 hours of productivity a week. How did that translate in your own practice?
Well, you know what's interesting is I feel like there are phases to being an endometriosis patient, right? I feel like before diagnosis, often, you know, patients can spend decades losing out on education, losing out on work, you know, having stressors within, you know, relationships. So chronic fatigue, all of this stuff happens even before the diagnosis. And I think that's an extra level of trauma for patients, is being sick for so long and being dismissed for so long and not knowing what's going on. And then, you know, when they finally do know what's going on and do get a diagnosis and, you know, maybe have access to collaborative care, you know, there's still like a big impact on their everyday life. And they still, you know, have all of these challenges, but at least then knowing what is going on offers like some hope and some relief, I found.
Do you think that enduring so much minimization and trauma changes who somebody evolves into, like the teens with endometriosis, things like that? Yeah,
Now I can hear you.
okay,
It from the way you were talking, it looked like a very good
very
question.
important question. My question was, think about our teens with endometriosis. Do we think trauma changes who they evolve into as a person?
Yes, absolutely. And I think that's why, you know, a lot of, I'm sorry, I bumped the table. A lot of the centers of excellence have called for an endometriosis experts and, you know, multidisciplinary care providers who are experts. They are pushing for early diagnosis, early treatment, and early access to collaborative care. Because if you can, and that's why, you know, the Endo What school nurse initiative is so important, because if adolescents can get diagnosed early and get the resources early, what I found, and also what this author argues, is that collaborative care early on can help minimize trauma. Endometriosis is a very difficult disease to manage and treat, but if a patient can have collaborative care early, it can really change the course of their life.
So I want to add that the endometriosis, nurses educator kit is a partnership in our Endo Summit workshop. And any nurse that registers for Endo Summit workshop, which by the way is 70% sold out. So if you're buying a ticket to that, better hurry up and buy. But that you can register and get the kit with CEUs in it for an extra fee. So let's just talk about the third level of trauma, and then we have a whole bunch of questions and comments.
I'm reading the comments. There's some really good comments there. I saw one about a huge power imbalance. Oh, I have so much to say about that. That's such a great point. So level 3 trauma talks about, really, it's usually in a hospital setting. So for endometriosis patients, a level 3 trauma can look like, well, actually, I have to tell you, when you're experiencing intense pain, it really, and you go to the ER, you're basically dealing with a level 3 trauma, right? Because it feels huge. You're in a ton of pain. So I think endometriosis patients, you know, when you go to the ER for intense pain, that's a level 3 trauma. When you get an MRI and it, you know, may show that you have a bowel obstruction, you know, if sometimes in the rare patient, endometriosis can, you know, kink through your ureters or block them off, and you can have a failed kidney. Ectopic pregnancy can be life-threatening, and, you know, endometriosis patients are more susceptible to that. So it really happens in the ER setting, and it feels like your life is in danger. And, you know, at the rare occasion, your life may be in danger without like the proper treatment that you need. And I think what's important to speak to this is that, unfortunately, because in the emergency room, often the doctors, the providers there don't understand endometriosis. So you go in, you're in intense pain, and then a lot of times patients are dismissed, and they're definitely not given the resources that they need to thrive and get the care that they need. So the level 3 trauma can feel, it's very scary, and unfortunately, there aren't enough resources for the emergency room doctors and providers. So patients get dismissed, and that adds to the trauma.
Right. And I think that every surgically diagnosed endometriosis patient has been through level 3 trauma, because putting an incision in your body, if you look at it, actually Dr. Arrington gave a wonderful, the Center for Endometriosis Care gave a wonderful talk at AAGL on the science of the cellular trauma that happens just by putting an incision in. So there is a physical trauma that happens in terms of the central nervous system being upregulated, in terms of tissue damage. And so then you have to add to that we do not operate in a bubble. We're not people that live in a bubble, and you can't separate physical from psychological. And I feel that every time we have to go through surgery, it's psychological trauma. You know that. You have to do a bowel prep. You have to make sure, like, I'm not a parent, but my patients with kids say they have to make sure they have a will before they go for surgery. It's very, very traumatizing. I personally, 2 years in a row, walked into an ER. The last time I was in the ER, I ended up in the hospital for 8 days with major life-altering surgery. So there is always a component of trauma. And I think it's time the endometriosis community reached out and explained that this goes on. Let's answer some of our questions. The first question is, how do you cope when reaching out to mental health or physical health providers who are unable to receive, I'm assuming you mean correct information? So that's from Rachel. If Rachel has clarification, that would be very interesting.
Yes, let me just, I'm going to go up. I'm going to go up and read. Yes, I think maybe what Rachel's talking about, and she can correct me if I'm wrong, is oftentimes you try to give information to providers and you try to educate them and let them know what's going on, but because there's such a lack of awareness and education amongst the greater medical community, and really also in the mental health provider, like that community as well, I think it's really important to advocate for yourself. And if you can find another doctor who's more open to receiving information, I know I've sent different articles to therapists about endometriosis and about trauma and about grief, and they've been very open to receiving it. Sending the Endo What documentary, sending trusted websites, the Center for Endometriosis Care, like they have a great website. And then hopefully providers will listen. And if you can't see another provider, I have to tell you, my gynecologist now in town, like, is not aware of endometriosis, is not really helpful. And it was a little traumatic for me because she had to do my aftercare. I traveled to a center to go have surgery, and I just braced myself. I realized that she does not understand, she does not know, and I just I got what I needed from her and left. So I try not to let their dismissal get to me because I know better. But it's very hard, and it shouldn't be that way.
Yeah, I think also what I find also, if you really want to educate a medical provider, how about buying them a ticket to the Endometriosis Summit? Let's not
I think
leave
that's
that out,
great.
right? So one of the things that we did as a community was we donated tickets to major medical organizations so that they can send their residents. So we have a whole bunch of, so that hopefully the next generation of doctors, they'll understand the patient voice, because our program really is about the patient voice. But I also have to say, oftentimes, Rachel, you will hear from providers that you try to educate, they'll just turn around and throw your pamphlet in the garbage, or they're not interested in watching your movie or whatever, because they are busy and overwhelmed. And sometimes I start that conversation with them by saying, I know you're busy, I know you're overwhelmed, but I really suffered it. And, so like I try to play to them a little bit, because otherwise they're not interested in hearing. Okay, let's see if there's another conversation, another question.
I like the thought about power imbalance, and the doctor is in a position of authority and you're not. And that kind of speaks to what you were saying. Part of the issue is that, and it brings us back to standards of care, the standards of care right now are terrible. And, when you say to provider, this is not right, look, I traveled to this provider and they were wonderful. Or, if you go to the Endometriosis Summit, where the top experts, come together and talk about endometriosis, none of them are saying what you're saying to me in this office. But part of the problem is, the standards of care are terrible, and providers will say, well, look, the standards say this, like, what are you talking about? So it gets tricky when you're up against these doctors who are not open, and also who are relying on the age-old standards that are actually harming and traumatizing patients.
I think there's a huge power imbalance also, in that people know that we don't feel well and we're losing productivity and we can't have children and we can't function, and we become prey for them to profit off of. So I see it all the time. I definitely see it in the marketing of some of the new drugs that are on the market. This is not a conversation about that, but it's like, how do we take your suffering and manipulate it for our profits? And that, I think, is some of the power imbalance. And I also see it, there aren't that many excisionists around. And believe it or not, I have patients that are exposed to doctors I myself was exposed to one, and they're going to use their power, or they're going to hold your healing hostage. And so that power imbalance, so I see that a lot in Canada. I know Violetta is from Canada, because she told me in the comments. And I think, like, because you're on the list and there aren't that many excisions, they sort of like hold your health against you. And the only way I believe that's going to change, and I know Casey's like on board with me with this, is for these patient groups to rise up, and is for projects like the Nurses Educator Kit, and you know, all of the grassroots campaigning, things like Nancy's Nook, the ERC, for us to just like not take it anymore, because the power, we definitely have the power. We may have lost some of the power of our own body, but our voices usually work, and we're going to have to learn to use them. So let's
yeah, the author talks about, she used the term medical narcissism.
I can't imagine that. I've Casey and I are friends. I'm sure she's heard of that before.
I have, and you know, they talk about doctors with God complexes who are not interested in collaborative care. And that's a really big problem. And the author says, you know, collaborative care is key. When you have a whole team that's patient-centered, working towards the best interests of the patients, and everyone kind of has equal power in that relationship, including a mental health provider, including like a pelvic floor therapist and the excisionist, and all these people coming together as a team. That's how you help minimize trauma in a patient.
I also believe that having that multi-pronged approach prevents one from being the God in it. So like, it's almost like a checks and balance system, because if the pelvic physical therapist is saying one thing, but the urologist is saying another, but the nutritionist is saying another, our goal is to make the patient healthy, and it allows like sort of a built-in check and balance against like the surgeon, because we don't always want them just hacking whatever out. I know somebody on here has already commented they lost an ovary without knowing it was going to happen. I also had that happen. I know plenty of patients that have had tubes missing, whatever. And I think that multidisciplinary care helps minimize trauma in those situations, because, you know, we want to make sure that if something's coming out, it's your true cause of pain. So the other concept, Rachel commented that a lot of mental health professionals say, I don't know the medical piece. And how do you combat that in a mental health counseling session?
Honestly, I think if I was a patient talking about why I was there, and why I was there was partly because of, you know, my chronic pain, you know, traumatic surgeries, the secondary losses, and stressors that are coming from this disease, and the provider doesn't want to hear it or doesn't feel like it's appropriate to talk about in therapy, you definitely need a new therapist. So I think mental health providers need to work hand in hand as part of like a team with other providers, because mental health is such a huge piece to it. And this author talks about how providers can, you know, test for trauma. Like there are certain instruments used to see if a patient may have trauma, and then they can be referred out. Or, you know, one day I would love for all centers to have, you know, mental health providers, fertility centers, excision centers, to have a mental health provider right there to talk to patients.
Yeah, that would be awesome. So we have a comment about we have to break the chain of providers that automatically recommend hysterectomy. Can you talk a little bit about how that impacts someone's psychological well-being, that hysterectomy is always thrown at, like I've had 23-year-olds and they say you could have a hysterectomy to a 23-year-old, you know, like how does that play a role in, and as somebody who sees also the other side, that if you have adenomyosis, maybe you want a hysterectomy. I chose with adenomyosis to have the adenomyomas removed because I didn't want a hysterectomy. And it actually had, my reasons had nothing to do with childbearing, but what do you think this constant endometriosis is fixed by hysterectomy? A, where do you think it comes from? And B, what do you think we can do to help minimize the trauma that that induces?
Well, it comes from the standards of care. It's written right in there. ACOG has it written right there. One, they tell patients to take hormonal medications or Advil. Then they recommend doing surgery, which what they mean by that is ablation. And then a patient may have, several ablation surgeries, like years of hormonal medications, neither of which treat endometriosis. And then what they call the definitive treatment is a hysterectomy. So patients all the time are told to get a hysterectomy, or, oh, you should get a hysterectomy, when we know that endometriosis itself is disease outside of the uterus, and a hysterectomy is not treatment for endometriosis. So, I mean, we have petitioned and we have told ACOG, we have sent them research saying that a hysterectomy needs to be taken out as the definitive treatment. My heart breaks for patients who will find me after a hysterectomy and say, I'm reading this now. They told me hysterectomy was my only option. I got a hysterectomy. I'm still in pain. Like, now what? Now what is happening? I mean, you talk about trauma. It's terrible that this is going on and that this is allowed, and not only allowed, but recommended by the majority of providers.
Yeah, so Carrie brings up an interesting point. She says in the comments, they tell you when the uterus is gone that your pain can't be real. I mean,
Yes,
if that isn't
they're gaslighting patients. Yes, Carrie. Like, say, oh, you don't have a uterus or ovaries anymore, so you shouldn't have pain. It's so terrible. I mean, talk about like the impact on mental health.
I also will say, as somebody who does the comprehensive eval, from a physical therapy perspective, you want to think about, okay, if the person had adenomyosis and the uterus is gone and the pain is still there, was the pain caused by the uterus? Because A, endometriosis pain is not caused by the uterus. B, hernias, which I see hernia probably in 50% of my patients or more. And they all point to the lower quadrant, lower left or lower right quadrant. And then the doctor will haul off and go take out an ovary, but never actually fix the area that's damaged. Is it abdominal wall issue? Is it pelvic floor dysfunction? Is it interstitial cystitis? Is it a nerve compression? Is it pudendal neuralgia? Like, are we looking at a wide enough, thing? Like, I know a lot of you are from the same area. If you have pain during sex, then they always call it vulvodynia. Is it really vulvodynia, or is it hormone dysfunction from having that uterus out too early? Like, is it pelvic floor? Is it a lot of other things? And I think that that's traumatizing. We should do one, we're going to have a lot of these live things. We should do one where we just talk about sex.
Yeah.
We could talk about the trauma involved in sex. I mean, maybe Casey will come back. I don't have anyone scheduled next week. We can think about it.
And the sad part is, advocates and experts have been going for years to ACOG, fighting ACOG and telling them that the standards are wrong. And ACOG is not listening, and it's causing further trauma in patients.
Yeah, I think that also it's traumatizing that it's hard to access care. So wait, we have not being able to have sex during the pain. Does that oftentimes cause trauma for patients? I'm a pelvic PT, so I see that all the time. I'm gonna go with yes. I think it also affects the connection that you have with your partner, even though there's plenty of other things to do. And so then a partner saying, not getting it because it's hard to understand, and it's very traumatizing. It impacts a relationship a lot. That's why we're going to have a sex and relationship panel. And actually the audience, is going to sort of get up and run around the room to answer all the questions. It's going to be very fun. But that happens too. The other side of it is, we have a comment that says, the uterus is gone, so the pain is gone, but the trauma remains. So what's the point in having sex?
Yeah, and it's I know for me, like and for a lot of patients, I had adenomyosis and fibroids as well. I chose to have a hysterectomy last year, and like having a vaginal cuff and thinking about intercourse after that it was a little traumatic for me, despite like I had an amazing surgery and, a lot of my, all of my uterine pain was gone. But man, like it's hard. Intimacy throughout this whole process, it's really hard.
Yeah, it is. I think every aspect of the human psyche is affected by endometriosis, and then half the world wants to just say, well, we'll fix it with a hysterectomy, even though that doesn't fix any of those components that we talk about.
My doctor basically said in my post, I had to have my post-op checkup here, right? Like my 6-week post-op checkup. And my doctor was basically like, sweetie, I'm so glad you got a hysterectomy. And now, it's, didn't you suffer enough for so many years with endometriosis? I'm so glad you finally did this. And, and I was like, ah! Like I wanted to, but I just smiled because my legs were up in the stirrups and she was checking my cough. And I was like, this is terrible. Like it is just.
And it's that power shift. You don't feel really powerful as patients. I remember actually one of the ways that the Endometriosis Summit got founded was because a doctor just was going to hold my health hostage, and that I was retrograding into my belly, and I wasn't retrograding into my belly. And the amount of pressure it took to just walk towards the door and move into a new care team, that itself was traumatizing, because you trust this person, and then you have to leave because you have to save yourself. It's almost like you're in the battlefield and you have to decide whether you're going to stay in the swamp and that's going to be it, or you have to go and save yourself. And so it takes a really long time to heal from an experience like that. And then we do surgery and people think like in 2.5 weeks you're healed, but it could take years to heal the trauma of what went on.
Yeah. And I have to mention too, like, and we probably won't discuss it in depth tonight, but there are people who have, besides endometriosis, have other traumas that they have experienced, which compounds this. They maybe have anxiety or depression or other mental health challenges that compounds this. There are other patients who have like other life stressors, and it all makes this, difficult. And, we know that African American women are more dismissed for pain. We know that they're more likely to have a hysterectomy for benign conditions. So institutionalized racism compounds this for some patients. So, there's so much going on for just any individual, and then you add endometriosis and infertility, or maybe on top of that pregnancy loss, and it's very, very difficult.
Okay, if there are no other questions, Casey's going to give us a brief summary of what we discussed tonight. So we are getting some new questions. We definitely have a question. I do believe the African American community suffers greatly with endometriosis, and they are tremendously minimized. And most of the time told it's fibroids when it is endometriosis, and accessing care becomes really hard. And then there is another about, how do you get over the trauma when you have to go to surgery again? I can give some practical advice, and then I'm gonna ask Casey to sum up very specifically in a very specific way. Do you have some practical advice for how to go through surgery when you've already been so traumatized?
Yes, I'm also reading and how do you think of, I can't get over the trauma of thinking they won't find endometriosis. I tell you, that's something shared with every patient. I talked to 2 patients earlier today, and the whole, what if they don't find anything? Will they find anything? I thought that way too. And from what I hear from different surgeons, often the first thing out of a patient's mouth when they are just waking up is, did you see anything? Did you find anything? I think it's just something, again, with mental health support. Whenever I was preparing for a surgery, I made sure I was up on my therapy and talking about these questions. What if they don't find anything? What if I go through all this and nothing comes out of it? But mostly, I think if you, for the majority of patients that I've worked with and for myself, if you feel like something's wrong, if you're in pain, then most likely something is going on. And if you talk to a specialist and they think something's going on, it's definitely worth investigating every time. Even if to just rule out endometriosis by an expert, it's just worth taking that step of further investigation. But it is hard.
Okay, Casey, I realized, I did not know, at the bottom of the screen, there's something called Q&A, and we have questions in there, so we have to answer these. The first one from there I'm going to answer is, it says, Casey, what types of therapy are you using with your clients?
Okay, I am currently not practicing, but in the past I have used cognitive behavioral therapy. I found trauma-focused cognitive behavioral therapy is very helpful. Usually you take a patient who's in crisis and you kind of get them through the crisis, and then you eventually get to a place of, talking about mindfulness and relaxation, other therapies that the author recommends in this book, and that I know other patients have found with other therapists. There's therapy called EMDR, which is eye movement desensitization and reprocessing. I had a patient who had great success with that.
I also went through EMDR because I couldn't ever be in a room with bright lights from all the surgical. Yep. And what they do is they retake you through the trauma and they repattern your brain.
Yes, they
sound great with it.
Yeah, reprocess unresolved trauma. I hear it's phenomenal. There's also somatic experiencing is another type of therapy, because Sallie, you were saying this before, that we often carry trauma in our bodies.
Right. So
there are certain therapists who are trained in this, who take you through body movements to try to release the trauma. And then there's mindfulness and mindfulness-based stress reduction, which Sallie and I often would practice in tandem with patients. And I know you use mindfulness and relaxation a lot for pelvic floor therapy with your patients, and I have used that a lot too.
So we will explore mindfulness at the Endometriosis Summit workshop, because we will do a yoga and meditation workshop. And in New York, there is a somatic therapist that works specifically with pelvic pain, and maybe we can talk her into coming to Endometriosis Summit 2021. And we will see. So there's another question in the question and answer. I think that the minimizing can also come from family and friends who don't believe symptoms, which totally increases anxiety and depression. How can you give 2 good strategies for working with family and friends that don't believe symptoms?
Again, I think this is where a therapist comes in handy, because I know I had family members when I was going through infertility to say, like, I think you just want to get pregnant too badly. You should just forget about it. Or the non-understanding. So I think that's where regular therapy can help. Talking to a therapist, venting. Ultimately, I think what has to happen is you have to understand that your pain is real and your experiences are real. And for whatever reason, if your family and friends can't support you, you have to put them in a place where they can't harm you, if that makes sense. Like a mental space where you have to like tune it out and just, find other people who understand and support you. I think that's where also support groups can come in handy, because I think a lot of us patients can experience minimization and dismissal from family and friends. So joining, some of the groups online that are supportive, where you are around people who do understand, can also help, because you could say, Like my mom's like just being totally dismissive, and she wants me to do all this around the holidays, but I have my period, and someone else can be like, oh, that's crazy. You know, just understanding, getting that understanding from other patients, I think can be helpful.
You know where you could get not only a lot of support and camaraderie is really sitting in an audience at the Endometriosis Summit town meeting with 363 other people who have endometriosis, but then also bringing the friend or family to the Endometriosis Summit, because perhaps they don't understand. And I think being where there's other people, like when you send a parent into the Nook and she can see it's not just my kid.
Yeah.
Or it makes a huge difference. Yeah.
I also Endowood is a phenomenal film to show people who you know, may not understand. I did a video as well about the emotional impact of endo and infertility, and that people have told me, especially you know, if you're in a relationship with someone, that it's been helpful. So there are definitely resources online that can help.
Okay. One last question, and then what is your opinion on doctors recognizing your symptoms, but then just telling you to go on the pill? Like, not from, we could talk about the medical perspective in another Facebook Live, even though we're Zoom Live, but what is your opinion? What do you think that does to somebody's mental health? Because clearly the pill doesn't help.
Honestly, I think anytime a patient doesn't get true informed consent, it is a trauma to the patient. And it causes physical consequences and also emotional consequences. It's one thing to give a 17-year-old all of their options, which going on the pill certainly is an option that can help some patients for, you know, maybe help with alleviate some symptoms for some time. But that patient also deserves to understand and know about excision surgery and about pelvic floor therapy. That patient deserves to know about mental health support for all of the secondary stressors that's going on in you know, his or her life that's happening. So my opinion, I'm very sad about this state of care, and I know that it's causing more trauma in patients than need be. I know that if a 17-year-old got the option of collaborative care and got all the choices that they need to thrive, trauma would be less.
Yes. Okay. So Casey, before we close out, I want you to give us 3 strategies to help overcome trauma with either your endometriosis or the endometriosis of someone you support.
3 strategies would be to find an excision specialist that believes in collaborative care, find a really good therapist who understands about trauma and who understands about chronic illness to support you throughout the many different phases that you'll go through. And number 3 would be to find your people, find support, whether it be online at the summit, you'll find lots of support, but find your people where you can vent and find people who understand you and uplift you and get you and who won't dismiss you.
I actually have to say, Resolve New England, that's their hashtag, find your people.
Yeah.
So, excellent, Casey. Casey's my people. So we loan her out to all of you, but she's definitely my people. She will be your people at the Endometriosis Summit workshop on February 29th. We are just wrapping up here tonight. This is Casey Berna. You can reach Casey at caseyberna.com. The other thing, I am going to share this link over to Facebook, and I think Casey will hang out in our comments for the next couple of days if you tag her, and she will try to answer them. I will try to answer also. I also want to say we really only had one mention of doing surgery here, but an entire hour of discussion, and I think that brings up the point that the excision surgeons may cut out the disease, but there's a lot that needs to heal, and it takes a whole body approach And we, as advocates for endometriosis, need to begin to embrace that, and that it isn't just about therapy, or it isn't just about surgery, or just about PT, or just about nutrition. It needs to be all of those things together. So
yes, and like with the best, most compassionate, most wonderful care, it's still a trauma. So I think that's important to realize that even in the most wonderful care, your body's still going through a trauma, and it's still traumatic, and that trauma needs to be addressed, you know, and supported by, like you said, a multidisciplinary team.
Absolutely. And we need to let your body needs to feel what it's going to feel. And if it's going to feel pain, it's going to feel pain. And if it's going to feel trauma, you need to provide that space. And that's exactly what Casey's going to do for us at the Endometriosis Summit workshop. We can invite Casey back. We are hoping to continue these live events throughout the year. And hopefully Casey will join us again. I am Dr. Sallie Sarrel, and I can be reached at salliesarrel.com or theendometriosissummit.com. Tickets are on sale. I just looked while we were on here. We are well into the well into the hundreds. If you're looking to come to the Endometriosis Summit, I hope you buy your ticket soon. And you can meet Dr. Chernovo is coming, Casey is coming, Nancy Peterson is coming, and of course, Andrea Vidali, endometriosis surgeon extraordinaire from Hoboken, will be your host for the day along with myself. All right, we are going to share this into Facebook. If you have more questions, you can put them into the comments. It's going to take me a few minutes to figure out how to do it, but we're going to get it done.
Thank you, Sallie, so much for having me. And thank you, everyone who's on. And I also see the amazing Heather Guidone is on. So I appreciate seeing her there. And thank you, everyone, for your patience in the beginning, but also for sparking a wonderful discussion. I really appreciate it.
And we're just sparking it. We're going to continue this. Good night, everybody.
Good night.